Hello, I'm Ralph Llewellyn, partner with Eide Bailey, and I'm here today to talk to you about the basics of healthcare finance for mid-level managers. I think this is an interesting title, as many leaders in healthcare facilities most likely feel that healthcare finances are anything but basic. Let's be honest, healthcare finance can be confusing at best, and it's not getting any easier. So today, we will focus our discussion on the basics of the extremely complicated and confusing business model. It has been said that the healthcare industry is unlike any other. That's not meant to imply that it's more complex or that it takes a rocket scientist to figure it out. It just means it is different, and it can be confusing. The finances of most other businesses are fairly straightforward. On the revenue side, you generate a sale, you generate a charge or an invoice, you send a bill out, you get paid for each item that you bill for, and you actually expect to get 100% of that payment. Healthcare may have been like that years ago, but it's definitely not the way it's done today. In today's healthcare environment, we have multiple reimbursement methodologies that may provide incentives that may appear to be or are in direct conflict with each other. You add these various reimbursement methodologies to the fact that most training for healthcare leaders avoids this topic completely, and you're set up for a disaster. If healthcare finance has you confused and frustrated, understand you're not alone. We'll start with the traditional models, of which there are many, and then we'll move into the more complex, more recent trends that we've been seeing in the industry. Our first methodology is charge-based payers. Charge-based payers are those payers that pay us at full charge or percentage of full charge. The majority of payers used to reimburse under this methodology. The percentages that we see may vary in the market as well as by payer. The level of negotiation in this model can also vary, with less negotiation available if the payer or provider is dominant in the position, or more negotiation if they are of comparable strength in the market. Historically, we have liked these payers, as they better allow us to manage our revenues and our cash flows. It's also easier with these payers to determine how much net revenue each department is delivering to the organization. Unfortunately, these payers are dwindling in number in the market. The next methodology we encounter are prospective, also known as fee schedule payers. These payers come in all forms. They may be negotiated rates, which are often common with commercial payers, or they may even be mandated rates, which often happens with governmental payers. Example of governmental payers could be Medicare physician fee schedule, Medicaid, the VA, and workers' compensation, and probably many others. Under the prospective payment methodologies, CPT and/or HCPCS codes are reported to determine the payment level to be received. In these situations, proper documentation and CPT or HCPCS code capture is more important than the actual charge, as long as the charge exceeds the contracted fee schedule. The need to have a charge that exceeds the fee schedule is important, as payers will typically pay the lower of the charge or the fee schedule. Over the years, many governmental and commercial payers have begun to modify their payment methodologies to bundle multiple CPT and/or HCPCS codes into a single payment level. As in the previously noted prospective payment methodologies, it is the documentation and CPT and/or HCPCS code capture that drives reimbursement. It is important to note that the lower of charge or fee schedule limitations may or may not apply here. For this reason, it is very important to monitor individual contracts. Since multiple services and/or items are bundled into a single payment, it may not be possible to assign net revenues to departments for these payers. Hospital inpatient services may also be paid in a prospective manner. Diagnostic-related groups, or DRGs, are the common methodology. Under this methodology, the reported diagnoses are grouped into a single DRG, which is converted to a payment level. In this model, it is the documentation and the selection of the reported diagnoses that drive reimbursement. CPT and/or HCPCS codes do not have any impact on the reimbursement in this model. As in the case in other bundled services, there is no ability to accurately assign net revenue to each department. It is also important to note that under most DRG payment methodology, the DRG payment is paid regardless of total charges. Finally, there are cost-based methodologies. The most common cost-based methodology is the Medicare payment to a critical access hospital. In some states, Medicaid may also use the cost-based methodology for reimbursing the critical access hospital. The cost-based methodologies will include a completion of a cost report and the use of interim payment levels. To better understand the cost-based methodology, one must have a high-level understanding of the Medicare cost report. The Medicare cost report can be thought of as being similar to that tax return that we fill out as individuals. The cost report is a document where the facility reports its activities, its volumes, and its revenues and expenses, as well as makes certain elections for handling various components. The cost report then compares how much the facility was reimbursed in interim payments versus how much they should have been paid to determine a settlement amount. Again, much like a tax return. It is important to note that Medicare does not recognize all costs as allowable. And even when a cost is determined to be allowable, Medicare does not pay for 100% of that cost. Examples of unallowable costs in an organization would include advertising, some interest expense, televisions and telephones in patient rooms, and much more. Once the total amount of the allowable cost is identified by department, Medicare will then pick up its portion of the cost based on the utilization of Medicare in that department. It is not uncommon for the cost report settlement to result in a payable or a receivable at year end of several of hundreds of thousands of dollars in a given year. Since there is a cost settlement, payments throughout the year are based on estimated levels according to claims submitted. This is similar to the withholding that's done by our employers for income taxes. The interim payment levels are based on the last filed Medicare cost report, unless the Medicare administrative contractor has additional information to be considered. While the settlement of a couple hundreds of thousands of dollars may sound large, it may be a variance of less than 1% to 2% of the estimated interim payments.
So managing to the value equation in healthcare is a very counterintuitive prospect. It is making investments to reduce the demand for the services that actually generate our revenue and, in essence, pay our bills and pay our salaries. So it is a very difficult situation to sometimes feel like we should be engaged in. However, what we've done with our mid-level leaders and to try to educate everybody is that's a short-term focus. If we don't do it, someone else will do it to us. And quite honestly, we think that we can do it better for our patients and our communities than anybody else can. And we would certainly rather control our own destiny than have it be controlled for us. So what we see as it relates to these investments and these efforts is that it will build faith in the patients that we're always doing the right thing, even if it's hard to do, that we will see our employers and the payers, insurance companies, and patients and our community at large increase their faith in the organization, and in the long term that faith will repay itself for us on a return on investment through enhanced commitment and engagement from our patients and communities, and we would expect that engagement to be realized through enhanced market share, enhanced volume, the ability to add new programs, and even in our philanthropy efforts.
Over the past several years, we've seen a movement from volume-based reimbursement, such as the models we've talked about already, to value-based reimbursement. While we will explore several variations of the models, the overall goal is to drive down the cost of population health by shifting the incentives and rewards for payment and quality. The most common methodology you may encounter is accountable care organizations, known as ACOs. Medicare defines ACOs as groups of doctors, hospitals, and other care providers who come together voluntarily to give coordinated, high-quality care to their Medicare beneficiaries. The goal of coordinating care is ultimately to ensure that the patient gets the right care at the right time while avoiding unnecessary duplication of services and at the same time also preventing medical errors. When an ACO succeeds both in delivering high-quality care and spending healthcare dollars more wisely, the ACO will share in the savings it achieves for the payer. Now, when we look at these savings and look at these models, some models may be one-sided, meaning that the provider only shares in savings with no risk for the increases in expenses, while others may be two-sided, with a sharing of the opportunity for savings and risk for increases in costs. As one would expect, in a two-sided model, you will typically see a provider getting a higher share of the savings in return for the taking on of some of the risk of the additional costs. When we look at ACOs, they can involve both Medicare as well as other payers. As noted, the involvement of ACOs is essentially voluntary at this time. However, the pressure to engage in these models is growing as additional incentives are created for organizations engaged in these methodologies, as well as competitors using these methodologies to capture increased market share. Boards, the C-suite, department managers, and providers frequently ask, why should they want to engage in these models that essentially appear that they would result in reductions in total reimbursement? All of this happening during a time when you're already struggling to manage increases in costs and dwindling reimbursements. Let's be honest, that's a great question and a valid concern. Let's discuss a couple of items for consideration and then take a deeper dive into strategies. Consideration number one is the reality that population health models are gaining momentum. The second consideration is the fact that many of the early programs appear to provide for lower risk and/or greater forgiveness on the front end for early adopters. So early adopters may be able to learn new strategies during a time when there is less risk, while also positioning themselves better against their competition in the long run. But to do this, you need to know the strategies. The first thing to gain an understanding of is the fact that there is money to be made in wellness services. For years, the industry pushed back on payers with the complaint that the lack of payment for wellness services was a big part of the problem, which led to the drive in higher healthcare costs. Over time, the coverage of wellness services has increased substantially, especially with Medicare. Unfortunately, we find a large number of providers and patients have not taken advantage of this increased level of coverage. From a Medicare perspective alone, there is the Welcome to Medicare visit, the annual wellness visit, chronic care management, transitional care management, preventative screenings, and much, much more. Not only do you get paid for these services, but many can lead to the provision of additional services that are necessary and appropriate for the patient. As an example, the annual wellness visit is a planning visit that can lead to over 25 other appropriate services to be scheduled and provided. Not only are these appropriate services for the beneficiary, but many are available without additional out-of-pocket expenses for the patient. Under chronic care management, it's not uncommon to see an increase in clinic visits, as the clinic staff are better monitoring the patient and identifying potential needs much earlier in the process, which leads to an increase in the number of office visits. Properly implemented, the adoption and promotion of these services can have a significant positive impact on departmental utilization and revenue for the departments rendering these services. But if there's money in wellness and ACOs provide incentives for savings, you may very well be wondering where the savings come from. the savings can be found oftentimes outside the walls of your organization. This is especially true for rural providers. It is true that some of the savings from preventing admissions or readmissions into your facility will have a potential impact on those departments in your organization. However, the larger savings can be found in the reduction in the need for outside services such as air ambulance and costly interventional services at tertiary providers, as well as through improved referral patterns. Also, increased engagement in annual wellness visits and chronic care management services can also improve medication reconciliation, which can lead to improved medication management, increased medication adherence, increased medication effectiveness, and overall reduction in medication spend. The last potential benefit to the provider of being engaged in an ACO methodology and the related services is the ability to use the program to expand your total market capture. There is an opportunity to better promote the improved patient experience from increased contact and communication that is part of the provision of chronic care management services, provision of identified screenings, and benefits of early detection and prevention. The ACO model is not the only model attempting to address the issue of population health and its underlying cost. Numerous models exist and continue to be developed. It is important to monitor these models as they are a great indicator of the potential models that may become prevalent in the future. The Pennsylvania Rural Health Model has been established to test whether care delivery transformation, in conjunction with hospital global budgets, increases rural Pennsylvanians' access to high-quality care and improves their health, while also reducing the growth of hospital expenditures across payers, including Medicare, and improving the financial viability of rural Pennsylvania hospitals to improve health outcomes of and maintain continuing access to care for Pennsylvania's rural residents. Ultimately, this program tests whether the predictable nature of global budgets will enable participating rural providers to invest in quality and preventative care and to tailor their services to better meet the needs of their local communities. 2019 was the first performance year of this program, the first of 6 performance years. The Center for Medicare and Medicaid Innovation has also established the Community Health Access and Rural Transformation, also known as CHART model. This is a new model. It's an additional model with the aim to continue addressing health disparities by providing a way for rural communities to transform their rural care delivery systems by delivering innovative financial arrangements, as well as operational and regulatory flexibilities. There are several other alternative payment programs and models, including the Comprehensive Primary Care Plus, Bundled Payments for Care Improvement Advanced Model, Comprehensive Care for Joint Replacement Payment Model, and the Maryland Total Cost of Care Model. While each of these programs vary in the goals and the incentives, they're all focused on improving quality and access to care, while also delivering it at a lower cost.
Well, the role of mid-level leaders in terms of the long-term success of an organization like ours in managing the value-based care equation is that we're all in it together. That we can't have silos within the organization, that we can't attempt to work to the exclusion of any of the rest of our team, or not without the best engagement possible with our patients. We also have to realize that the best strategy without great execution is simply dreaming. And it's the mid-level leaders who really have that role, again, as the connector between strategy and execution, and the interpretation and communication to our staff and providers to help us achieve the goals of our strategy and the goals of our mission and vision.
Financial impact of value-based care is actually the big question right now, because as you know, the payment under the value-based system is totally different than the majority of the payment we receive today, which is the fee-for-service world. So the term, the shaky bridge, is so true, because a lot of the things that we're doing to get ready for population health, but they're things that we're really not being paid for yet. Because today we're still primarily based on a volume-driven system, where fee for or value-based, we're going to be paid for value. So it is somewhat of a transition, but from the community standpoint, it certainly has a huge financial impact, because the whole cost is to create a better lifestyle and a better quality of life for our community as we reduce the cost of health care.
So, what does all of this mean to the middle-level manager in the healthcare setting? It means a couple of things. First and foremost, it means that the financial challenges experienced by facilities and managers is not likely to go away. But more importantly, the need for C-suite and middle managers to better understand the various reimbursement methodologies and their varying incentives has never been greater. The financial realities require our leaders to not only be technical experts in their specific areas of expertise, but also possess a high-level understanding of the financial factors in their department and in their organization. The success of our rural healthcare provider is dependent on this. Thank you for participating in this discussion on the basics of healthcare finance in the rural healthcare provider setting. I wish you luck in your continued adventure.
For additional information and resources on any of the topics covered in this module, see the resource guide that accompanies this program. And of course, please feel free to contact us at the center anytime for additional support. And we have a request. We need your feedback. On the main webpage dedicated to this series, there's a Give Feedback link. At any time during the course of this series, or even multiple times, please go to our website and share what was valuable for you and any suggestions you have for making this series better. We thank you for joining us today, and we look forward to continuing the conversation over the next few months.